Hello, everyone. Welcome to our webinar on health equity and systems leadership. We're really excited to have you all with us, and we hope that this will end up being an interactive webinar and that you'll glean some useful information from it. We always welcome your comments and questions, whether you do it in the chat box or using the question and answer feature. And so, again, thank you for being here.
And this webinar is recording.
Thank you, Lisa. So for today's agenda, you'll see that we'll start off with an overview of why we care about the topic of health equity, why it's important to the mission of ICS, and a brief glimpse at what things are looking like now with COVID-19. So we'll then get into an overview of systems thinking, just basically explaining to you all what it means to be a systems thinker and what systems are. Then we'll go into a bit about COVID-19 and why health is in crisis in this country at this moment, but also specifically in South Carolina. We'll go through some demographic information. Finally, we'll get to the question of what do we do now? We've heard all of this information. We've heard about systems. What can we do to really effect change and foster health equity across South Carolina and the country at large? Next slide, please. So as far as our mission goes, as you see here, we do have a mission that's based in equity. We know that in order for all children to succeed, that we need to sometimes have a special focus on populations that are marginalized and have needs that may be different in order to achieve a mission of equity. So what is equity? So here you'll see two different but related definitions. And the thing to take away from this slide is the idea, or I should say, are the ideas of impartiality and fairness, and also the idea of meeting a person where they are. So when we talk specifically about health equity, we're referring to access and having no limitations, and no limitations in particular based on those characteristics that may make a person or a community different, whether it be race or ethnicity, zip code, urban versus rural, whatever the case may be. Those things should not become barriers to achieving access, and then after access, having quality of care. Social determinants of health are 6 categories, generally 6 categories, the ones that you see here that are often referred to as kind of the indicators of what the quality of one's health look like. So you see these 6 categories here. So something like, for instance, food is the 4th category over. It's looking at whether or not a community has a hunger issue, whether or not there is access to healthy options. So oftentimes if the answer to those questions are no, then we know that the determination is more than likely that health inequities exist. So here you'll see a depiction of what it means to evolve from the status quo, but also what it means to be on the way to equity, whether it's health equity or any other kind of equity in society. So here you'll see that the rectangle in the middle, which depicts a state of equity, is a case where people are given what they need. And oftentimes when you ask folks about equity, they'll say, oh, it's the image of the people on the boxes. So here are the people on the boxes. So giving people what they need. The people in this image need different number of boxes. One doesn't even need a box to achieve an equitable level of access to the field that they're all trying to view. In the third rectangle, you'll see what systems change looks like. And really it's a removal of barriers. No longer are the boxes needed. So there's currently an urgent health crisis, which is probably not something that is new to anyone on the call at this moment. What we do know is that many of the inequities that we see today, many of the barriers to health equity already existed before COVID-19. Many are historic inequities, and so having a COVID-19 global crisis have just highlighted those inequities that already existed. So next we'll get into our overview of systems thinking, and Brian will walk us through that.
Thank you, Mary. So whenever we talk about systems change work, we often start with the parable of the river, which is a mental model for social services and systems change that it evolved out of it came out of the community organizing movement. And in that community organizing movement, they were trying to describe how you move into the systems change and the organizing work. And it starts off with, there's this community by the river. And there's a person fishing on the river, and all of a sudden they see this young child, almost a baby, floating down the river and at risk of drowning. And so they go out and they get the kid, and they bring the kid back off of the river. And the response to that child begins the social service network. They have to find a way to provide food security, to provide housing, to provide a family. Adoption systems are set up. And then, so that's sort of the seed. And then the next day they see another kid coming down the river. And so this continues for a while, and they have this robust social service system. But it's getting to be a strain because it's a small community that's sitting by the river. And then one day, somebody who's working at retrieving kids stands up and starts walking upstream, and everybody's like, "Wait, there's kids coming down the river. You gotta come back." And this person says, "Yeah, I'm gonna go up river and see who's throwing the kids in." And that such begins the thinking of systems change. It's not to diminish the very incredibly important work of the social services sphere, but it is to say that there are things that we want to work ourselves out of these jobs. We want to try and solve these problems at the root. Another model for systems change, another framework that people often use, is this social ecological model. And it comes out of the Health Equity Resource Toolkit from the Centers for Disease Control, actually. And it's, anytime you get to play with the nested egg logo, you want to. But it starts at the individual level, where you have the most impact in some respects over a small number of people. And if you can adjust the systems of an individual or a family unit, it can have a very significant impact on that small number of people. And then basically you step out through interpersonal, institutional, community, and then policies and systems until you reach a point where you're having a potentially very significant impact on a very large number of people. And in the systems change thinking world, there are kind of two frameworks for systems change. We had the animation there a little backwards, started with 2 and moved to 1. There's Peter Senge's 11 rules, and that Peter Senge is often described as the founder of the systems change movement, but for sure one of the ones who founded the language around systems change. And then the Waters Foundation has published a framework of 14 habits. And those habits, if you ever need something to stick on your bulletin board, it has some nice iconic ways of looking at the habits of system thinking that can be useful. We're going to walk through because we only have an hour, and we could talk about systems change for quite some time. We're going to walk through just a few that seem to be some that are very helpful starting points. Anybody who's interested in diving into this more, we're happy to get into it more in other contexts, and also there are resources that you can pursue. But just to touch on a few of the key ones. The first one that we like to talk about, because this seems to be one that is incredibly impactful, is that causes are not always closely related in time or space. And so the habit of a systems thinker is recognizing that fact, and recognizing that often there are delays between what caused something and that result, and also spatial distance between it. So the example from the icon here is, the kid eating a lollipop. and then needing to go to the dentist. So, 6 months later, and quite a bit of distance between the candy store and the dentist. One that we like to talk about because it's a very sticky idea. It's easy to remember, is what a lot of people don't realize is that the #1 predictor of violent crime in a community, and this goes across all communities, cross-cultural, cross-linguistic, the whole kit, is ice cream sales. And so if you were to take that at first blush, you might think, well, we should stop selling ice cream. But in fact, it's not the ice cream that's causing the violent crime. It's that violent crime also correlates very strongly with heat. When it's very cold outside, violent crime goes down. And so it's a reminder that the clear data connection is not always the connection that leads you to the solution, but it is informative. So you can say, well, obviously this doesn't make sense. Ice cream is not causing violent crime. And then you can try and figure out what that story really is behind the data. The next one is that small changes can produce big results, but that the sources of the leverage are not often obvious. And so really having a strong understanding of how the system works now is often the prerequisite for figuring out the good leverage point. The example that we often talk about on this one has to do with retirement savings, of all the strange things. When retirement plans were first instituted at the federal level as a tax opportunity for tax sheltered savings, they were kind of disappointed when the policy passed because nobody was using it. And what they decided was, well, the way we structured it is you had to go to your employer and ask to be put into it. And so what they did was they allowed businesses to instead of that opt-in option, create an opt-out option where employers could say, okay, we are going to automatically create this account, and you can, if you don't want it, you can tell us that and you'll come out of it. And enrollment and savings went through the roof. People had much higher engagement just because of that little tiny change. It wasn't coercive. It just made it which one was the default. And that little tiny change had a dramatic impact for a number of families. The next two are pretty related to one another. It's that the first is that today's problems come from yesterday's solutions. And then the sort of highly related corollary is that the harder you push, the harder the system pushes back. And the example we often talk about in this one is from the early childhood education space. And it's specifically from the expansion of Tennessee's preschool system. So when if you happen to be following the expansion of Tennessee's preschool, they did what a lot of advocates, including myself, were really hoping they would do, and they provided substantial systems expansion for essentially providing full access for low-income families to 4-year-old preschool. And they paired it with a really rigorous evaluation. And they were a little disappointed at first because the data showed a faster, quote, fade out than they would have wanted in a more substantial one. And to their credit, they went in and they looked at what the standards were like and looked at what the best practices suggested. And they saw that one of the gaps they had was that they didn't have as many certified teachers in those classrooms as they would have liked. And so they said, we're gonna staff these with certified teachers. And so they did that the very next year and staffed them all up. And it was the next round of evaluation showed that the kids were doing worse. And they didn't understand what was going on. And when you talk to the researcher who went in and did the evaluation, she said, they did everything the way that you would have wanted them to in some respects, but the classrooms they became more negative. And when you went in, you saw scolding, you saw a lot of negative feedback from the teachers. And it was because they didn't have enough certified preschool teachers. And in order to staff those classrooms, they had to get certified teachers from older kids' classrooms. And so you had people who are used to teaching 8-year-olds or 7-year-olds trying to then manage a classroom of 4-year-olds and 3-year-olds. And that's an entirely different skill set. Whereas in retrospect, what we would have wanted if we could go back in time is to say, okay, let's let these teachers get certified. Let's let the preschool expert teachers who are there, who have those skills, let's build up their professional development. It's slower, it's harder, but this sort of reality is an example of both of these things that, if you push a little too hard, you can often have unintended consequences that you never would have predicted going into it. And that there's real value to, when you're doing systems change work, to testing and iterating and paying attention to these things before you scale at full throttle very quickly. And then the last two we're going to touch on is that oftentimes the behavior gets better. I'm sorry, the behavior gets better before it grows worse, and that faster is slower. And we're just going to very briefly touch on those because that last example also plugs into how this flows. So I feel a little guilty because we're talking about a topic that we love and we would love to go into for quite a lot longer, but we only have about 45, 50 minutes today to cover a lot of topics. So we're going to pass it back to Mary now. And feel free, though, to reach out to us or ask questions during the discussion section about the systems change piece. Mary?
Thank you, Brian. It takes a while to find that unmute button. So we're going to continue on with our next section. And so as you've heard before, first it'll look like a bit of a landscape of COVID-19 in South Carolina, and we'll have some hopefully informative and interesting poll questions for you. And then second, we'll get into highlighting two of the main barriers to health equity, which are poverty and racial discrimination. And so our disclaimer as an organization is that we know that there are so many more barriers to achieving equity of any kind, much more to achieving health equity specifically, but we have a limited amount of time. So those are the two that we have chosen to focus on for today. Next slide. So as you see here, there is a disproportionate impact of COVID-19 in South Carolina. Black people are 27% of the population in South Carolina, but make up 43% of the cases. So a second disclaimer that we have here is that the information that you'll see, the demographic information, obviously is something that changes each day, not as rapidly as it did maybe a month ago. We've done our best to be updated. So what you see here is accurate as of yesterday, and yesterday's data reflected information from the day before. So it might be slightly different today. Next slide, please. So there is a racially disparate impact in South Carolina that is even more evident when we look at COVID-19 deaths. So again, at only 27% of the population, Black people end up making up 50% of the deaths in South Carolina. So we have seen that there are higher rates of women who are diagnosed with COVID-19. However, in South Carolina, men are more likely to die. This is a statistic that was very surprising to me personally, because I feel like all I've been hearing all over the news is about how men are, when we talk about gender, men are more likely to both get COVID-19 and end up dying from it. So it was very interesting to me to see that, at least for South Carolina, women make up more of the cases, but when a man gets it, he's more likely to die than a woman is. And again, that is specific to South Carolina. If we had all the time in the world, I would love to take each of these stats and compare them to what it looks like across the country. So when we look at the pre-existing conditions that are existent in those individuals who have succumbed to COVID-19 in South Carolina, these are the top 5. So things here that stood out to me, I don't know what may be resonating with you all, you can let us know in the chat, but that asthma didn't make the top 5. That was a shock to me. I don't know that I would have thought that the top pre-existing condition would have been cardiovascular disease. Diabetes was not a shock to me, but again, you know, it's interesting to see what this looks like. So for the lung conditions that are not asthma, you might be interested in knowing what that means. So those are things like COPD, bronchitis, and emphysema that are coming in at 27% of fatalities having them. And then you know, it was interesting to see also intellectual disability on here. And, you know, I am not a COVID-19 expert, nor am I a doctor. It's, you know, it's a reminder that correlation is not necessarily causation. But, you know, again, it's interesting to see what things have made the top 5 list specific to South Carolina.
I do want to interrupt a moment. We had a question from Sherry asking if that diabetes, if that's type 1, type 2, or both. Do you know?
I am not sure. I think that it's type 2 diabetes, but that is something that I will look into and get back to you with the answer. That's a very good question for clarity. And so here you see a side-by-side depiction of number of cases versus rate of cases. And we've already gone into what that looks like. You know, it's good to know numbers, but of course that doesn't tell us the rate of what the infection or illness is looking like. Next slide, please. Okay, so now we're getting into a discussion of poverty as a barrier to health equity.
Do we have a poll for this one as well? Do I remember that correctly?
Not yet.
Okay, gotcha.
Okay, so here we'll see federal guidelines, federal household poverty guidelines for 2020. So looking at this slide, the way that we can interpret it is that a single person household is in poverty if they are making, they're at 100% of the poverty level, or they're in poverty if they are making $12,760 or below each year. Now, that may seem like a really low threshold. That's why we have the different percentages that are listed here. So there are many, there are programs that are available for folks who are living in poverty, and oftentimes they will go up to 200%. So that's why you see these different percentages. So a one-person household who is making $25,520 a year would still be considered living in poverty. Next slide, please. So again, similarly, we see in South Carolina for a household of 4, it would be an annual income of $26,200 or below. One other click here. So that would that would be the same as a single mother of 3 who may be working at a fast food restaurant. Next slide. Okay, so here you see a map of states, a map of the population that is living below poverty level by state. So in 2016, for South Carolina, 14.1% of the population was living below poverty level. So we have a related poll question for you here. So if that was the rate in 2016 and now we are in 2020, what do you think has been the trend? Has it stayed the same? Has the poverty rate gone up? Has it gone down? What would South Carolina's poverty level be by July of 2019, which is what we have information for? So most of you are correct. In July, by July of 2019, for South Carolina, the rate of poverty was 15.3%. And for a bit of comparison, in North Carolina, by that same time, it was at 14%. In New York State, it was at 13.6%. And across the United States, it was at 11.8%. So definitely higher than the national average and also higher than the neighboring state of South Carolina and also a state like New York. Next slide, please. Okay, so looking at, now we're looking at a map of population not covered by health insurance. And this is also a map that is from 2016. So in 2016, 10% of the population of people who are age 65 and below in South Carolina did not have health insurance. And so we have a similar poll question for you to see if you think that rate has gone up or down since that time. So it looks like 22% of you say that it remained the same, that it is at about 10%. 44% of you said that it is 12%, that it's gone up to 12%, and 33% of you said that it has gone up to 13%. So the answer here is 13%. We rounded up a bit. So by July of 2019, the population without health insurance, age 65 and under, was 12.7%. And again, for comparison, North Carolina had the same percentage of 12.7%. New York State was at 6.3%, and the average across the United States was 10% by July 2019. And you know, just thinking about where we are right now with a pandemic and people losing jobs and just various things, I imagine that some of this information, you know, is different and might have changed just within the past few months. So here we have a special highlight on rural South Carolina, because we know that there are differences, rural versus urban. So what we do know is that rural areas fare much worse than urban areas in South Carolina. And there is a sense of urgency there when we are talking about poverty and just the ability to make a living wage and to survive and cover one's expenses and to take care of children, frankly, as well. Next slide, please. So this slide quickly highlights some racial disparities. Okay, we have something in the chat. There's a question from Kara Davis. Will sources for data included in the polls be included at the end for further digging? Yes, yes, they will. And yes, it'll be available to you. As we move on, there may be certain links that we will post in the chat, but we'll absolutely include this information so that you can take a look for yourself and have it as a reference. So again, looking at racial disparities in poverty and healthcare nationwide, these are really, really fresh statistics as of about a day to 2 days ago. So looking at coronavirus and looking at how it has impacted the Black population in the country versus the white population. So 13% of Black people make up a larger share of COVID-19 deaths, which again, probably does not come as a surprise, but what does that percentage look like? It looks like 23% of deaths when Black people only make up 13% of the population. So we have similarly discouraging statistics about insurance and also poverty. We're looking at 5.4% uninsured white people versus 9.7% uninsured Black people. And again, a whopping 28% of Black people living in poverty as of 2 days ago, these statistics versus 8.1% of white people. All right, so moving along to our second area that we're considering a barrier to achieving health equity, looking at racial discrimination. And so J. Marion Sims is someone who is historically known as the father of modern gynecology. He is also one of the reasons in history that there still remains today a distrust in many Black communities of medical and health systems. And we know that that is dangerous. We should be able to go and get help when needed and have accurate diagnoses and to be heard and listened to when expressing symptoms or whatever the concern may be. So he did experiments on enslaved women and children in the 1800s, and part of the torture that they endured was having medical procedures done without any kind of anesthesia. So a bit of history. And I mean, there are so many other things that you can look into if this is something that's of interest to you, like the Tuskegee air experiment, just a bunch of different things. So we are going to show a really quick clip to you, and it is called At Risk, Mothers in Childbirth. That link will also be included at the end of this presentation. It's a 13 minute kind of documentary that's on YouTube, and we're not going to play 13 minutes of it. We're going to play about a minute and a half of it, but I really encourage you to go and watch the whole clip. It's really interesting and informative, and it really sheds an interesting light on what healthcare looks like, in particular for our maternal mortality crisis. Yes, the joys of technology. Okay, volume all the way up.
Dr. Neil Shah is a professor of obstetrics at Harvard Medical School.
The pain is okay?
And a practicing physician.
Are you also saying that some of these C-sections are just not necessary?
Probably more than half of them.
And when complications do arise, says Dr. Shah, doctors don't always listen to their pregnant patients.
I think there is a dimension of gender discrimination. If a woman after a birth goes into a hospital with concerning signs of a complication, there are no rules for how quickly an obstetrician has to see her. And in fact, it's a routine case that it will take hours.
And statistics indicate that it may not just be gender that plays a part in dangerous delays, but also race.
If you're a woman of color in this country, especially if you're Black, your odds of dying in childbirth are 3 to 4 times higher on average in our country.
Why? Because you're not talking about access to healthcare. You're not talking about money or education.
No, and this is going to be hard to hear. We believe Black women less when they express concerns about the symptoms they're having, particularly around pain. And that's the common thread in all the stories we've been hearing in the media, including Serena Williams.
Yes, even Serena Williams, the world-class athlete who developed a pulmonary embolism after giving birth to her daughter last September.
We had a lot of complications, but look who we got.
She says that had she not insisted on receiving a CAT scan, she could have died.
We're leaving the hospital after 7 days, 6 days. It's been a long time.
If women with resources are at risk, imagine what happens to women without access to proper health care.
Okay, so we are going to stop the recording there. I don't know how jarring or not that may have been for you all, but I'm also going to stop my screen sharing now and return it to our slide presentation. All right, so we see Dr. Neil Shah's quote up here. He's a Harvard medical professor, an obstetrician, and just to reiterate, what he said, we, referring to doctors and medical professionals, believe Black women less when they express symptoms they are having, particularly around pain. For any of you that might have children or, whatever the case may be, this is mind-blowing. I think it's mind-blowing to some, and also maybe a sigh of relief that our doctors actually saying it for others who have been in this boat and experienced it, but didn't have the words to say it, or didn't think that someone would believe them if they said, no one listened to me at the hospital. I knew what I was talking about and no one listened to me. There are so many stories out there that are like that. So, just a reminder that racial discrimination in health is very real, and it is part of the reason for the maternal mortality crisis that we have in this country. Next slide, please. So when we look specifically at Black women, Dr. Neil Shah repeated that statistic about being 3 to 4 times more likely to die from pregnancy and childbirth related complications. But also, keep in mind that even at higher socioeconomic levels, Black women are still at risk. Black women are still less likely to give birth at the safest hospitals. And, that is something that may still remain surprising. I think that there's often this thought within society that once you reach a certain economic level, once you're successful or once you're you're wealthy or make a certain salary, maybe you're not wealthy, you're just doing well, income-wise, that, you know, you're in the clear, and that's not necessarily the case. Next slide, please. So moving on, after hearing, you know, about what the health equity, what the crisis around health equity might be in South Carolina and across the country, what do we do now? We've learned about system change, we've heard about health inequities. What now? What can we do to get to a place where we are fostering circumstances that promote health equity? Next slide, please. So when we talk about a system of inequities, here we see some of the characteristics of what inequity looks like. We've discussed equity a lot, but not necessarily what is its opposite, inequity. So in a random poll of 17 people, random survey, it wasn't anything formal. Some of the people surveyed were in the field, some were not. When they heard the word inequity, these are the things that really stood out as the qualities of inequity: injustice, unfairness, discrimination, things like that, dishonesty, disadvantage, structural violence. Next slide, please. And so looking at COVID-19, it really highlights a deadly access issue, which is also an issue of inequity. Here you see what I like to call is some of the faces of COVID-19. So all three people are folks who died as a result of having COVID-19, died recently within the past few months. So Reginald Self in Illinois, Kyle Brown in Iowa, Raina Zoe Munjan here in New York City, where I live. And the thing that they all have in common is that they were denied COVID-19 tests. So we heard in the media, oh, you know, if you need a test, you can get one. I know living here in New York City, where, you know, we were kind of the center of things for a while, unfortunately, you know, I definitely heard that. But I also know people personally who were very sick and could not get a COVID-19 test. And so the three people that you see here were sick, were refused tests. One of the people here were refused tests twice and ended up passing away. Next slide, please. So looking again at the group of 6 social determinants of health, we know that when we look at these different areas, economic stability, food, education, healthcare system, these things, social economics, education and food, healthcare, can either end up being a barrier to achieving health equity or a catalyst for promoting health equity. And that's something that we should definitely keep in mind. So another note, we've spoken a lot about equity, but nothing about inclusion as of yet. So access is not equal inclusion. It's good to have access to healthcare, but is it quality healthcare? And so what does it mean to be inclusive, whether it's with healthcare or anything else? Access says, oh, you know, I've been let in the door, I'm in the doctor's office, I have health insurance now. But what is the quality of one's medical experience? Is a person's voice heard at the hospital or in the doctor's office? Or when speaking to the insurance company? That has nothing to do with the doctor, and it's also something that, you know, ends up being such a headache for a lot of folks, and another barrier to attaining health equity. Do you feel a sense of belonging when you are in a doctor's office? Like, you can ask a question and get answers. All of these things really contribute to having an inclusive experience. It looks like there's a question in the Q&A that came in just now. Or it might be a comment. As a former, and it's from Tia Prosko, and I'm sorry if I did not pronounce your last name right. As a former breastfeeding peer counselor for WIC and someone who is still passionate about postpartum issues and women and children's health, I am reminded by those statistics in that clip that our higher maternal mortality rate also means the rates of breastfeeding are also lower. Sadly, this continues the generational impacts of health inequity, but this is a driver for me to keep my certification as a lactation consultant and keep working for children and families. Thank you, Tia. That's such an important point, that if a mom has passed away, if the baby is still here, there is a baby that probably won't be able to get breastfed. And we know that breastfeeding is really important to the development of children. So thank you so much for highlighting that. Next slide, please. Okay, so the big question, how can we promote health equity, particularly during COVID-19 and also beyond? So the American Hospital Association recently put out a few guidelines around what we can do to really improve this situation that we all are in as a country. And so the first step is to educate in a way that resonates with every patient. So in other words, you know, tailoring that message, understanding that people are coming from different places, and really think about messaging around how we educate folks about what's going on. And part of education and messaging is being sure that your message is heard. So it might mean something like, you know, sharing information at a location that has meal drop-offs where we know people are going to be, or at a place of worship. You know, definitely sometimes have to get creative when we're trying to reach our intended audiences. The second thing is leveraging community partnerships. So again, you know, none of us can do this work alone. So definitely figuring out where we can have strategic and strong and effective partnerships. Collecting patient data. You know, this is one that probably cannot be stressed enough. I'm a person that is very much moved by stories, but I understand that, you know, the importance of having data, and that it reinforces the stories that we hear, and it reinforces the things that are actually going on in people's lives. If we don't have data, how do we know at a larger scale, not just at a person to person, we heard this conversation, we heard this story, this person told us that, but how do we know that there is a large issue at hand? How do we know of large scale inequities? So we need to continue to collect data. The fourth thing is advocating on issues that address the disparities of COVID-19. And these disparities of COVID-19 are also disparities that existed before COVID-19. They've just been highlighted for the most part. And then finally, of course, which is part of what we're doing today, is sharing what you learn. Next slide, please. I'll kick it over to you, Brian, talk about advocacy.
So on that prior point here, where we're talking about the advocacy balloon, you can look at a lot of this work as advocacy work. And so one thing we wanted to emphasize here is that advocacy does not mean just getting people to call their legislator. It does not mean just hanging out in a legislative lobby and talking to legislators. It has a much broader context. And one thing that's important when you're looking at governmental action is that policymakers, elected officials, and their staff, they're human and they want to do the right thing, and they, generally speaking, have no idea what that is. And that's not meant as an insult to them. It's, you know, they come from whatever professional background they come from, but they're very often not educators or doctors or equity experts or the like. They come from whatever profession they happen to be in. And so they deal with that in a couple of ways. One is listening to what their constituents want, and the other is listening to what experts say is the course of action that they should be taking from the expert perspective. And they do that in different degrees based on the different legislators. So there's a lot of advocacy for many of the people who are on this webinar. You're both a constituent and an expert for many of these issues. And so you have a unique amount of leverage with policymakers if you can do this cycle of educating and leveraging data and analyzing data and speaking to your legislator about it. When you're looking at lobbying, there are a couple of subsets of lobbying. There's the please vote this way on this bill, and then there's the grassroots organizing, or getting a group of people together to say, hey, we would like you to vote this way on this bill. And those are important to pay attention to because they can be very effective. They're also important for a lot of us because they have implications for our 501c3 status. But one thing we do want to highlight is if you're interested in engaging in this, 501c3s and other nonprofits are legally allowed to do this. There are some limits on what they can do. And we're happy to talk offline with anybody who's interested and get into what some of those limits are. But I think there's a knee-jerk reaction about how, oh, we can't advocate or we can't lobby because we're a C3. And that's just not true. One other quick contextual point is when you're advocating and you're talking to a policymaker or to the community, one of the things that's most powerful for non-experts is not the stats. Those stats, X percentage are experiencing Y outcome, they're important, especially to data geeks like us, and that's useful. But what sticks in a policymaker's mind most quickly is a story about what happened to a constituent, talking about the mom's experience in the hospital. And that's also what sticks with your next door neighbor. And so being able to bridge the divide between the geeky data side and the story that tells is one of the core elements of advocacy. And if you can get that down, then it's not just you and your call sheet that's making these issues apparent to policymakers. It's also your next door neighbor and their next door. And I think, Mary, I'm going to pass it back to you now.
Right. Thank you, Brian. So we're almost done here, we promise. And so thinking about equitable policies, what do equitable policies champion? So here are a list of things to consider. Of course, the obvious: access to high quality healthcare, obvious but not always easy to make happen, we know. Supports for parents, early interventions, we will always champion that as an organization that has a mission of ensuring the success of all young children. Race conscious measures, we've seen the data, we know that it's an issue, so we have to pay attention to it, and the same goes for socioeconomics. Next slide, please. So, racial equity assessments, it is a recommendation that we have here. And so you'll see this on the list of resources. What you see here is an image that was created to depict the South Carolina Racial Impact Equity Assessment Guide from 2017, and just some of the guidelines that are there. So really being intentional about work. If you are a policymaker or a person or organization that is able to influence policy, always thinking about what the impact will be on the people that the policy is meant to serve. Who are the stakeholders? And a word here about stakeholders, I think a lot of times when this word gets thrown around, it looks like this fancy, shiny thing. Stakeholders are people with money. Stakeholders are those people with influence. Stakeholders are your community members as well. So, just a reminder to, always be centered around the needs of the community and the voices of the community. Looking at the outcomes, and then also looking at any kind of change that you might want to affect, and also a change that you might have to make to a policy as well when you realize, oh, it's inequitable, it has these unintended impacts, and we need to go back to the drawing board. And so, we talked about having a racial equity assessment. We know that urban versus rural is a source of great disparity, particularly in South Carolina. So being intentional about that as well. How does a certain policy impact rural areas in particular, since you know that rural areas are already poverty stricken, and that there are certain challenges specific to those areas? What are the differences in how policy will impact rural members of the South Carolina community versus those who are in urban areas? Next slide, please. So again, just looking at what it looks like and what it takes to evolve from the status quo and to effect system change. Those recommendations are some of the ways that we, encourage you all to get out there and be on the road to fostering health equity. Again, definitely not something that is simple or something that is easy, but as long as we keep these conversations going, keep sharing our resources, keep having these partnerships, leveraging these partnerships with one another, we can begin to be on that road. Perhaps it doesn't look like a whole, systems change where every barrier is broken down yet and none of the people need boxes to stand on. Maybe we're still making sure that boxes are available for folks to stand on to get to that place of equity. And that's okay, as long as we keep doing the work and we realize that there is a system that does need to be changed. Next slide. Okay, so a few of you have already put out some questions there. We have 6 minutes left. So we want to know if there are any other questions that are out there, and we'll go ahead and get to the next slide with resources while we wait for your questions. And thank you, Lisa. Lisa has just provided a bunch of the different links in the chat so that you can go on and check them out for yourself.
And for those who are trying to capture those real quick, we will also be sending those out later. But we're not. We can leave this open for a minute if you're trying to copy and paste anything. Checking to see if there are any raised hands in the audience or anything like that.
There's a lot more that could be said about this issue. Brian and I once delivered a one-day training on the same topic, so trying to condense into 1 hour was definitely a challenge. And we had to shorten things a lot and also practice, make it fit this 1 hour webinar. So we know that we didn't cover nearly everything that could be covered on the issue of health equity.
We did not. Or systems change.
Or systems change for that matter, yes. Okay, we can move along to our next slide, which I think is our final slide. So our webinar series continues in 2 weeks on June 18th. And that webinar will highlight the impacts of COVID-19 on South Carolina's childcare sector. There was a survey that Institute for Child Success put out there for the South Carolina community of workers in the childcare sector. And we have the results and we'd like to share them with you all. So definitely, if you haven't registered for this webinar as yet, it's at the same time in 2 weeks. You know, we definitely encourage you to join us to hear about what those survey results look like. Some of you may have already seen glimpses of it in our communications to you, but it's also an opportunity to ask questions in real time and also share your own experiences as well.
And I can't look at this picture without smiling at the kitty cat with the mask.
Yes. All right. I think that we are all done here and on time, early.
I think Lisa, am I still the host? Is that right? I think, yes, okay. So for folks who are trying to capture down any of the resources from the chat window, I'll leave this up for another couple of minutes before I have to hop to the next thing. But thank you all very much for joining.
Thank you. And feel free to send any of us here an email about what you learned today. If you have any questions, any comments, any kind of follow-up, we'll be happy to continue the discussion with you. Or even if you have suggestions on future webinars, something that you'd like to see us do, that would be great. Thank you.
Mary, I'm going to put your and my email in the chat window.
Okay, thank you. Sherry Gilliam says, thank you. You're very welcome. Thanks for joining us. Tia as well said you truly enjoy what you got to hear, interested in the topic. Yes, thank you for sharing, Tia, your perspective on breastfeeding and the maternal mortality crisis impact on breastfeeding. Definitely an overlooked point.
All right. Lisa, you just went off mute. Were you about to say something?
No. Just thanks everyone for joining us.
All right. I think we're probably in a good place to close it down. Thanks again, everyone. We enjoyed having you, and we look forward to next time.